Hello. And this is the most difficult part is to start. And being totally honest, I think there's one song that you all may know that really that will make you understand how do I feel. And it's something like, words don't come easy to me, how can I find a way to make you see? I love you, words don't come easy. And this is what I feel with you, I love you all. Thanks for being here, really, my pleasure. I couldn't find how to introduce myself and how to thank you all. Okay, my lecture, when Maurice told me to talk about bioengineering, I took a look at the schedule, and there's 4 speakers talking about the same topic. Quite hard. I'm also in the 3rd Spanish speaker, and honestly, I think both of them did it so well. Now it's quite difficult. So not an easy situation. But I think I have something new. More than 80% of the slides you're about to see are totally new. No one has ever seen any of these slices. So hopefully we'll have time enough to see the majority of them. As the previous speaker said, there are different kind of English. We have American English, Spanish English, Italian English, and we have also chaotic English. This is my English. So I'll try to do my best. I'll try to slow down because I want you to understand everything I want to share with you. Okay? First thing, I would like to introduce you my island in a hippie way. This is, this is how Ibiza is. This is the best thing of the lecture. She's a friend of mine. There's more than 35 people working now with me, and I have to congratulate Eduardo. I don't know how he managed with more than 50. Unbelievable. Now it's people coming from all over the world. And I try to teach everything that I do. I think a good speaker is someone that is not able to do magical things, someone that really is passionate about sharing what he's doing. And I really am. Okay, now, what's my lecture about? My lecture is about how to solve cases like that, like this one, or maybe like this one, or like this one. This is the lower jaw. I think the most difficult area. We have the muscles, the mental muscles here, and we have the floor of the mouth here. Look at the quality of the soft tissue. Also, cases like that, same thing. So what I did, cases like that, high expectations. And I did something, I twist the case selection into the worst possible situation. So you're going to see only cases with combined defects. This is not horizontal, not vertical, both at the same time. We're going to see all my cases that I'm going to share with you have more than 12 millimeters in height of bone loss. They all had previous implants, and we have to extract them. And the quality of the soft tissues is a total disaster. And maybe this is, for me, the most important part, the last point here. From 80 to 100% of the new implant is going to be in regenerated bone. We have, I have made a study, and we have more than 256 implants that are located in 100% regenerated bone. This is for nothing. I think this is really quite an interesting paper to go on. 100% of the implants in new regenerated bone. So this is not about, some threads, 1 or 2 millimeters. It's about 12 or even more millimeters of bone loss. So what is bone, what it is, and what it does? I want you to understand from the very beginning, from the basis. So I don't care if I have no time. I'm sure I won't have to explain all my lecture, but I want you to understand the basis. If you do understand the basis, then everything's quite simple. I'm not magic, and I know no one is. So you can do everything that I do, every single procedure. And I want you to understand. I'm sure you will. So what is bone? Quite simple. Bone is no more than a collagen type 1, but it contains mineral. Where is it? Of course, it's a part of the skeleton. And what it does? Simple. It gives us support and contributes to calcium regulation all over the body. Okay, so I want you all to collaborate with me. We have two rows here. It's quite simple. I'm going to ask you something. Are these two cells bone? Is this bone? Say, is this bone? No, they are, come on, this is something. These are red cells. Okay, what about this one? Is this bone? No, this is connective tissue. And here we have epithelium. On top of the epithelium, we have keratin tissue. Okay, it's keratinized tissue. What about this one? Maybe, this is bone. Is this bone? No. That was bone. That was bone. You can see the holes here. There were some osteocytes, but it's no bone anymore. It was, but it's not. And the worst thing, it will never be bone again. So don't get confused. This is not bone anymore. And remember, it never will. This is the worst thing. There are many implants around there that are put in situations like that. Sorry. Thinking, I don't know how people think here in the US, but in Spain, you have, imagine this is a dental symposium in Spain. Over 90% of the audience will think that bone is quite simple. Something is white, it's hard, and if you use a bar, without saline, it smells like like a nail or like a hair. But this is not bone. This is not bone either. And what about this? Is this bone? Only this is bone. You can see cells here. This is bone. And also, where's the pointer now? Oh, well, this is also bone. This was bone, and maybe it will be bone again. Okay. This is bone. We have also bone marrow here. This is connective tissue. But can you see this? All these cells contains a cell. And these cells are osteocytes. So don't get confused, please. So this is maybe the most common article mentioned in, I would say, almost in every lecture regarding bone. We know from 2005, from Araújo and Linde, that in our field we have two different kinds of bones. First one is the bundle bone, and second, the alveolar bone. I will add one more kind of bone. This is the skeletal bone. Okay? And let's talk about in this article, we know that since we remove a tooth, we will always lose, and there's nothing we can do, we will always lose this bundle bone. It's a tooth-related bone, okay? But in this article, it's quite curious. Look, the first thing that happens when you suck a tooth, you start losing the bundle bone. But the second part, this is in the conclusions. Second phase, what happens, it was not understood. We're talking about 2005. And I'm sure now, I know what deals this additional bone loss. And I want to share you with you all. Okay? Well, that article was done in dogs. Same thing happens in humans. When you extract a tooth, you are going to have for sure bone loss. First, you will lose the bundle bone, then the velar bone, and then the skeletal bone. In Spain, we were teaching in this sense, but it's not like that. This is not something that happened that first we lose bundle bone, then we will start losing our velar bone, and then the skeletal bone. It's not like that. The first two bones, which is the bundle bone and the velar bone, they lose this at the same time. But because of the first one is so tiny, it disappears, in just some months. Okay, let me invite you to an anatomical journey because I'm going to talk about the basics, that we must master the basics. And this article from Schroeder gives us a really interesting information about what is our field. So let me invite you to that journey. We are in the alveolar mucosa. You will see how this square here goes down. This alveolar mucosa is mucosa which is covered with an epithelium which is multi-layered, and it has two different turning points. The first one is the mucogingival junction. From here, we have a change, two changes in fact. The first thing is this epithelium gets covered by keratin, and also under this epithelium it was muscle and elastic fibers. So from this mucogingival junction, we start gaining keratin and we lose elasticity until we reach the second turning point, which is the gingival margin. Here, once again, we lose keratin till we get the sulcus. The sulcus is a real cavity that contains cells, bacteria, and clavicular liquid. Okay, so it's a real cavity. And then there must be some structures that join all this mucosa against the tooth. And there are two structures. The first one are this junctional epithelium. This junctional epithelium is made of series of cells. They get binded together by means of this desmosomic union. And look at this one. This is the hemidesmosomic junction. And it binds the cell to the tooth by means of this dense basal lamina. It's not a direct, let's say, fit. This is the first structure that joins the mucosa towards the tooth. The second one, this is the key. Second one is the gingival complex. Dentogingival complex is a series of fibers. They are connective fibers that participate in this junction. And it's totally different from teeth to implants. They are named as the direction they have. They are perpendicular, oblique, transeptal, interseptal, and these are the most important one, the perpendicular one. So I will join my good friend, not like like a huge. I will join him like getting into him. This is quite important. These fibers get into the tooth itself. Okay? Now, this is what we're looking for. This is the bundle bone. Here we have the dentin here, the cementum. You will see the cementum here does not contain cells because we are in this in the medium third of the root. As we go apically, you will see that some cells will start appearing here. Here we have the periodontal ligament, the plexus. This is the bundle bone, and this is the cortical bone. Okay, that is part of the alveolar bone. As we move apically, you will see here, you will see this is changed. From a cellular cementum, now we have cellular cementum. This is why Howie, he told us yesterday, we should remove the apical part of the root when we're doing a socket shield technique. Otherwise, we're leaving cells that can promote changes. So it's quite important to remove this apical part, in my humble opinion. We're leaving cells. These cells can proliferate. So why not? We have the chance. They are dead, so just cut it off. Now, this is for me, if I'm good enough to make you understand this slide, I will be more than happy. Okay? Is my English good enough to be understood? Yes. Really? I can change. I can speak. Now I'm speaking something like that looks like English, but I can speak almost perfect Spanish. Okay, so now this slide is really important. Now, on the right side, you are going to be cortical bone, and on the left, you are going to be trabecular bone. Please believe me, try to understand what I'm about to say. Here, we have cortical bone. Here, we have trabecular bone. Don't you agree? It is. We've been told during these 2.5 days that autogenous bone is osteogenic, osteoconductive, and osteoinductive. Do you agree? It's not. It's not anymore. And you will never say that again. Never, never, never. Because it's not real. And it's something that really, so sorry, really, I'm talking, you know, from the bottom. Really, it's something that gets confusion. Because we mix, we put everything together, from cortical to the trabecular bone, but it's not like that. So we should be precise when we're talking. So if we're using autogenous bone, we must add something, like a surname saying we're using autogenous bone taken from the cortical. This is not an osteogenic bone. It is not. It's an osteoconductive and osteoinductive bone. You will now understand why. So on the right side, you're going to be cortical bone. Well, you're many more than this one on the left, so you should gain. Okay, so cortical bone. What does it give us? Remember, what was bone? Bone was collagen type 1 with minerals, okay? So I'm going to ask you, what do you give me? Okay, your cortical bone, I'm going to ask you, what do you give me? I will say it first. Then you have to say it back. Okay, first, as cortical bone, you give me mineral, lots of mineral. Do you give me collagen? Lots of collagen. But you give me something else. Under this mineral is the collagen, of course, and once the collagen, gets exposed, BMPs are released. So cortical bone is the one that contains BMPs, okay? When we have a fracture, the osteoinduction comes from the cortical part because BMPs are released, okay? So cortical bone give us minerals, give us collagen, lots of mineral, lots of collagen, and also the potential to release BMPs. Talking about mechanical properties, what do you give me? You give me strength, okay? Easy to understand. Sorry. Talking about, now you are the trabecular bone. What do you give me? You give me mineral? Yes, well, a little bit. Do you give me collagen? Well, some. Do you give me BMPs? Not much. Okay? Do you understand that? But what do you give me? You give me holes. And these holes can contain cells. Okay. Talking about mechanical properties, what do you give me? You give me a structure that is easy to reabsorb. And because it contains holes, cells can get into. Okay? Did you get everything? Now I'm going to ask you, your cortical bone, please say it. What do you give me? Talking about minerals, do you give me? Lots, a lot. Okay. Talking about collagen, do you give me collagen? But how much? Lot. Perfect. Talking about BMPs, do you give me BMPs? Well, perfect. Now talking about mechanical properties, what do you give me? You give me a strength or you are weak? What do you give me? Strength. Perfect. You get everything. Now you, trabecular bone. Sorry, what do you give me? Talking about minerals, do you give me lots or just a few? Few, perfect. Talking about collagen, what do you give me? A few, okay. About BMPs, because it contains not much collagen, cannot release much BMPs, okay? Talking about mechanical properties, what do you give me? You give me holes that can contain cells, and you give me, I would say, resorbability, okay? Fast resorbability, okay? So, when we're talking about autogenous bone, we must differentiate what is cortical bone and what is spongiosal or trabecular bone, okay? Did you get that? Okay, now let's talk about the kind of cells that these different compartments contain. Cortical bone contains mainly osteocytes, and please, osteocytes are not an osteogenic cell. So cortical bone cannot produce bone by itself. Talking about the spongiosal trabecular bone, it contains mesenchymal stem cells with the ability, with the potential to differentiate into cells that they can produce bone. So, which of these two bones is really osteogenic? Cortical bone or the trabecular one? Trabecular one, perfect. You know what I've seen? I've been working in this field of bone regeneration now for 27 years. I'm 45, but I've been involved in this, working in bone for more than 27 years now. And what I see, when I take a bone from the hip, I put it in the mouth, and after, let's say, 16 weeks, I take a core. You know what I usually see? I send it to the lab, and they say me, I can see vital bone in a trabecular, shape, and it's mature. Why? How can this bone that has been grafted only 16 weeks ago be mature? There's only one explanation. Because it keeps alive. Has never died. Okay? It's the only explanation I have. While when I send him cortical bone, he always tells me the same thing. You have an immature bone. Why? Because it couldn't have time enough, or it couldn't have the good properties to survive. But because of the osteoinduction, because of the osteoconduction, the bone is coming in, is getting, okay? So totally different. Totally different. I have my biopsies there, my course, I can give you to. And you will see the same for sure. So now, please, when I have 10 minutes left, can someone tell me? Because, okay, now, what's bioengineering about? Quite simple. It's about cells, it's about a scaffold, and it's about signals. We all know that. But there's something else. Now, if we have time, we're going to talk deeply about cells, also about the scaffold. The scaffold has two different scaffolds. For many years, we've been using biomaterials only taking in consideration the mineral part. Now we know the organic part is key. This organic part is, of course, collagen. So mineral is good for osteoconduction, okay? And collagen is good, is necessary for angiogenesis. Okay. And now, talking about the signals, I have prepared some animations. If we have time, you will understand how everything works. Hopefully, we'll have time. But this is not only about having cells. This is not only about having the proper scaffold. We cannot control it. These signals must orchestrate everything. But we need something else. And this is, for me, maybe the most important part. We need the proper environment. We need vascularity. We need absence of mobility. And we need, of course, that there's no infection there. And we need also protection. This is, you can use membranes, barriers, everything, titanium meshes. It will depend. Now, let me introduce you, this is adult stem cell. It's a special kind of cell with the potential to develop into different types of cells. And these types of cells can be both hematopoietic or stromal cells. And there are both of these kind of cells are important for us. Talking about hematopoietic cells, there are two different branches. On one side, lymphoid, on the other side, myeloid. What is most important for us is the myeloid. So we have this hematopoietic cell that will give us this myeloid progenitor, then myeloblasts, then monocytes, and then macrophages. And now, this is the main bone maker cell. Which is the cell that makes bone? Osteoblast, okay. So this osteoblast has the potential to produce what is called osteoid, which is this kind of collagen type 1 with the potential to be mineralized. This is what osteoid is. Eduardo, he presented us a very beautiful animation talking about this provisional matrix. The first thing we have was the cover of the epithelium, then the provisional matrix, then this provisional matrix gets covered by a cortical bone, and then we have the bone itself. Okay. Now here we have the stereocyte. The stereocyte is a cell that is being sepultado, I don't know, it's being covered with the osteoid that gets mineralized. So we have, like, these cells that are just, they are there. For many years, they were underestimated. Now, we know they're totally key. These cells control the bone behavior. Okay? And now I have introduced you the good people. Now let me introduce you the bad ones. The bad one is the osteoclast. What he does is it removes bone. And it does it in two different ways. First thing, an acid attack. And then an enzymatic attack by means of collagenase. And now we have fibroblasts that promote the synthesis of collagen, type 1, and reticulin, which is the third type of collagen that is elastic, but also promotes the synthesis of endothelium growing factor. And you will see how important is the relationship in between angiogenesis and bone formation. I have explained you. What do you give me? You as cortical bone, let's say it again. You as cortical bone, you give me mineral, you give me collagen, you can secrete BMPs, and you give me mechanical strength. You are spongiosal trabecular bone, you give me not much collagen, not much mineral, not much BMPs, but you give me holes. Okay? Now I want you to understand. Once you know what do you give me, I want you to understand when you are in front of a recipient site, what do it needs? What are their needs? Okay? So we have prepared like a cartoon movie in order to make you understand what the specific site needs. What are their needs? So imagine that you've been in the desert for more than 10 days with nothing to eat, nothing to drink. This audio, you have, well, you give up, you have, the only thing you can see is sun for miles. You give up, you are totally exhausted. Then you find a lamp, typical lamp, you clean it, and then the genius appears. This audio, then the genius appears and offers you different wishes. But you must choose only one. So, if you choose the first one is here, that contains holes, do you really think in this stressful situation, will you choose the one with holes? Do you really think? Well, you will eat much less than if you choose this one. So it makes no sense. And will you choose this hard one? You're exhausted. You're going to take like more than 2 hours trying to ground that cortical, sorry, that hard cheese. No, I'm sure you will take this one. This is a juicy one, rich in proteins, but also contains a cellular phone that allows you to ask for help. This is what you need to understand. BMPs are something that gives you a choice to ask for help. So if you are in an environment that is totally, healthy, you have healthy, bony walls, of course you can put something in. You can put esponjosa. In fact, it will be the best thing you can put in because it will easily be reabsorbed. But it makes sense to put something. It makes sense to put cortical bone that it will never reabsorb into a container with healthy bony walls. It makes that sense. Okay, on the other hand, imagine you have a recipient site with a poor quality of soft tissue. If you have a poor quality of soft tissue and you take bone from the hip, looking for these cells, and you put it in, they will never survive. So I only take bone from the hip when I have a total disaster. I don't have any bony wall, but the quality of the soft tissue is good enough to maintain these cells alive. Did you understand that part? But when I have a terrible environment and the soft tissue quality is bad, I always ask for help. I need something that enhances angiogenesis, that promotes osteoinduction. So I need BMPs. I say it again, if we have a perfect environment with healthy bony walls, we can use osteoconduction. If we have a total disaster, but the soft tissue is good enough to maintain cells alive, you can use autogenous bone, but not the cortical. We can use esponjosa. But if everything is a disaster, the most intelligent thing is to ask for help. This is why we need BMPs in these situations. Let me present you this case. This case, he's a man. He's young, no more than 40 years. And he was sending to me because he loses implants there, and also in the upper jaw. Look, he told me that he loses his implants because he sneezes. Well, big sneeze. Okay. See, this is the lower jaw. And please, focus. This is the quality of the mandible. This is only cortical bone. We are in this side. We have not osteogenesis at all. And look at the soft tissue quality. So I will never use here. I will never use osteoconductive materials. There are not healthy bony walls. But I won't use either osteogenesis because the quality of soft tissue is so bad that they will die. So I'm asking for help. This is why I need BMPs. So how can I obtain BMPs? I can obtain BMPs from the cortical. Okay, and this one thing I have not explained. When we're talking about cortical bone, I told you, in fact, you told me, it contains collagen and mineral. When we are using allogenic bone that is demineralized, then it loses the strength, but it releases the BMPs. So the use of, if you want to obtain cheap BMPs, you should be using the mineralized cortical allogenic bone. Because these BMPs, because they mineralize, they have the collagen and all the BMPs are there. So the cheapest way to obtain BMPs is by using the mineralized allogenic cortical bone. So what I take what I call a dome. I call this technique canapé, because I prepare like a dome of cortical fresh frozen bone. Then I took the marrow, I remove it, I soak it into PRGF, and also add the mineralized allogenic cortical bone, asking for help. This one sentence, which is going to be really important. This BMPs promotes osteogenesis, but it's almost 100%, it's not 100%, but it's specific to the stem cells that are in the periosteum. They do nothing in the spongiosa, in the trabecular bone, while PDGF is more specific to the stem cells that are into the bone marrow. So if we're using BMPs, this is allogenic cortical demineralized, we need to make holes in order to allow BMPs to come out and to stimulate the periosteum. So whenever you're using BMPs or any type of BMPs, you need to make holes in order to expose these BMPs towards the periosteum. So this is what we're doing, more than 12 millimeters in vertical gain. This is what we did. Here you can see the floor of the mouth needs to be dissected. Also, sublingual granules were removed. And this is how only 16 weeks later, the outcome has totally changed. You can see its appearance. It's not too good, and I have to admit it. I always take biopsies from the area that looks the worst. And I send it, this is what they give me. They give me this cortical bone with osteocytes. And believe me, it looks like it was necrotic. I always send like a report. I fill down the paper saying, I think it's necrotic bone. And they say, well, it's vital. I get only 16 weeks later in such a situation. Now, we put you can see one more biopsy here. Now we do some nerve transposition, vertical gain, simultaneous, everything. I never do the second stage, but full thickness flap. And, well, we add some free gingival graft. We did something similar in the upper jaw. And we all know we have models in our clinics. Let me share with you who is my model.
Cuenta un chiste.
Tell us a joke. What you are going to do?
¿Estás contento con la prótesis?
Are you happy with the restoration? It doesn't hurt me. Well, thank you.